we're moving on to some complications of therapy, what to do if treatment failures, and what to do in specific populations, in particular CKD patients. Osteonecrosis of the jaw is associated mostly in bisphosphonates. And what that is that the jawbone is exposed and it has not healed. It's been at least 8 weeks or more, and it's not due to radiation. This is going to be more common in patients that have some risk factors such as older age, cancer, poor oral hygiene, or having an existing infection. It also varies depending on the medication that they're on or the specific bisphosphonate. So it's going to be higher in patients that are on the IV versus the oral bisphosphonate. And it's also going to be at an increased risk if they've been on it for longer. So usually like longer than 2 years. Also, it has been seen in patients that are on denosumab and romosozumab. There are some case reports as well. Now, to prevent medication-related osteonecrosis of the jaw, we want to make sure that the patient is getting dental screening, because the patient might not even know that there's an issue with that jaw, right? So that's a good chance where the dentist can catch that and we can do an intervention if needed. Now, let's say a patient needs a dental procedure done. Before we initiate a bisphosphonate, we want to wait at least 14 to 21 days before we initiate the bisphosphonate, and that's just making sure that it's properly healed. Now, let's say the patient is already on therapy and they need some intervention done, some dental intervention done. If they're on an oral bisphosphonate, it's been less than 4 years and they don't have any other risk factors that I mentioned in the previous slide, then we don't need to do a med change. However, if a patient has been on it for less than 4 years, but they do have risk factors, or they have been on the bisphosphonate for longer than 4 years, then in this point, we would discontinue the med for at least 2 months or longer, and then we could just restart the med after it has healed. Atypical fractures is another thing that can occur in patients that are taking bisphosphonates. What happens basically is a fracture occurs that you kind of don't expect to happen. So for example, here, there's a fracture with minimal trauma. So there's something going on with the bone. What is happening in atypical fractures is that there is this thing called frozen bone, where there's low bone turnover or low remodeling happen. Remember that there's that cycle where the osteoblasts and osteoclasts are clearing out old or damaged bone and making new and strong bone. The incidence with bisphosphonates is 3.2 over 100,000 patient years. This incidence will increase depending on how long they have been on the medication, similar to the osteonecrosis of the jaw. So as you can see here, when you're comparing 2 years versus 8 years, the incidence is much higher. Now, you kind of have to put this in perspective. Bisphosphonates are helpful. So for every one atypical fracture that might occur in a patient, this is not what we want. At least we are saving 100 or preventing 100 hip fractures. So when you look at it that way, that one atypical fracture it's not likely likely to happen when you're comparing the benefit of helping with hip fractures, for example. And so cases have been reported in, as I said, both bisphosphonates, but also in denosumab. Now, moving on to treatment failure. We don't have enough data to say which agent is the most efficacious. Like clinically, we don't have that data. But we do have some recommendations. So if a patient is on a weaker anti-resorptive, maybe it's reasonable to change it to something that's more potent. So for example, let's say they were on raloxifene, remember again for that specific population, then we might want to switch to bisphosphonate or denosumab. Another thing we could do is if we want to switch an oral drug, to an injected drug or another class. So we could do switching a bisphosphonate to an IV, so that would be zoledronic acid, or we could do denosumab or teriparatide. Also, another recommendation could be a strong anti-resorptive is reasonably replaced by an anabolic, because now we're kind of building new bone, right? So that could be PO or IV, bisphosphonate, or denosumab. That's your strong anti-resorptive. We can switch that to teriparatide or abaloparatide or romosozumab. Those are some anabolic agents as well. Now, looking at the CKD population, I mentioned before that the mechanism of osteoporosis is a little bit different in these patients, and that's why we don't have a lot of data on what to do with bisphosphonate doses. But let's say the EGFR greater than 130, and they don't have CKD-induced osteoporosis, then we could use bisphosphonate therapy. Now, when we get to 20 to 30, we might want to consider doing a bone biopsy to rule out that the osteoporosis is not from the CKD. So we don't have an exact dose to use, but if we're using PO bisphosphonates, we'd want to reduce that dose. It's not the exact dose that we want to give isn't important. Just be familiar with that. Raloxifene is another option that's not renally excreted, and denosumab also, it's not renally excreted, but be cautious because hypoglycemia can occur, and this could be detrimental in patients that have CKD already, where they're already hypocalcemic. And another option too is using teriparatide if there is a low or normal PTH, because again, PTH is another thing, or parathyroid hormone is another thing that is affected in chronic kidney disease. Now, let's say the EGFR is less than 20. Well, again, we want to encourage a bone biopsy because that's going to help rule out whether or not the osteoporosis is CKD induced. But we really don't know. We don't really have enough evidence to say which medication is going to be the best. But there is some expert data out there saying that one may be good or a certain dose could be used for this patient. Just be aware that there are going to be potential risks for complications because that medication is going to be building up in a patient whose kidneys can't eliminate the medication well.